In the FRCS trauma and orthopaedic exams, it's important to have a knowledge of the anatomy of the dorsal wrist extensor compartments on the back of the radius and ulna. And you should be able to draw a quick diagram of an axial section through the distal radius and ulna to depict the 6 extensor compartments. So to draw a quick schematic of this, what I tend to do is I start with the ulna and I draw a sort of blunted Pac-Man type figure there for our ulna. Then we come into our druge, and to draw a section through the radius, this is how millennial I am. I think about a Pokemon from the original 150 Pokemon called Ditto. You can just imagine its 2 eyes and its mouth along there, but that always gives me a very quick way to draw a section through the distal radius. This is our volar surface here, and then here's our first extensor compartment. We'll start on the radial side and work our way around ulna. So your first extensor compartment houses 2 tendons, both of which supply movements of the thumb. So these are abductor pollicis longus and extensor pollicis brevis, and that is within our extensor retinaculum, and a little subsheath there as well actually is our first compartment. Second compartment again has 2 tendons. Now these are, we're going a little bit more onto the dorsum here. These are 2 tendons which extend and radially deviate the wrist by inserting into the carpus. Therefore, we can remember these are extensor carpi radialis longus and extensor carpi radialis brevis. And that is our second compartment there. The third compartment is just on the other side of Lister's tubercle, which is this bony prominence just on the dorsum of the distal radius. Just on the other side of it here is our third compartment with a single tendon winding around Lister's tubercle to extend the thumb, extensor pollicis longus. In our fourth compartment, there's 2 things to bear in mind. One is our extensor of the index finger, extensor indicis, and then we can draw in, you can draw them however you like, next to each other, 2 on top of each other, whatever you like. These are our EDC, our extensor digitorum communis tendons, and that forms our 4th extensor compartment there. Drawing our 3rd. Then the 5th compartment is actually just on top of the druge, on top of the distal radial ulnar joint. So it's 1 tendon here, and that is our extensor digiti minimi, specifically for the little finger. And then our 6th compartment is another single tendon, extensor carpi ulnaris, on the ulnar side of the wrist for ulnar deviation and extension of the wrist. And there you have it. That is our schematic of the anatomy. Now, there are various conditions associated with each of these to be aware of, and as I say, it can come to you in a variety of situations and cases. So, starting with the first extensor compartment, this is where our patient may present with de Quervain's tenosynovitis. This is essentially a stenosing tenosynovial inflammation of that first dorsal compartment. It's more common in women. It's usually in the dominant wrist from overuse activity. It's more of a thickening of this extensor retinaculum as opposed to a true inflammation, but it causes radial-sided wrist pain because of the increased friction between this extensor retinaculum and the tendons. So the provocative test for this clinically is you ask your patient to grasp their own thumb and ulnar deviate the wrist to really stretch that first dorsal compartment, and that can mimic or reproduce the pain that they experience. And you can call that Finkelstein's test, as it's called in a lot of resources, or as I've been told, it's technically the Finkelstein's modified Eickhoff test, if we're looking for technicalities, but I digress. How to treat it? You can start with conservative measures such as rest, use of NSAIDs or a thumb spiker splint. You can offer the patient a steroid injection, which is often enough to give a very good relief. And for patients who are refractory to these measures, then you can consider surgical release. And in that instance, that is where this subsheath is very important to remember as well, because actually if you release the extensor retinaculum but leave that septum, then sometimes you can have recurrence or persistence of your symptoms. So it's very important to release both the subsheath of EPB as well as your extensor retinaculum as part of that procedure. Structures to be aware of: the superficial branches, superficial sensory radial nerve branches. We don't want to give our patients a neuroma or sort of chronic pain symptoms from nerve damage. So that's our first extensor compartment. In the second extensor compartment, our patient may present with intersection syndrome. And now, intersection syndrome is a condition that involves the crossing point, about sort of 5 centimeters proximal to the wrist itself, where the tendons of our first extensor compartment actually cross over the tendons of our second extensor compartment. And with repetitive motion, essentially, it causes inflammation, and it's an inflammatory condition at that crossing point. Again, therefore, the treatments or the options are fairly similar in that we can start with conservative measures such as rest, the use of a splint. You can move on to an injection into the second compartment, or in refractory cases, you can open up and consider a surgical debridement and release of the second extensor compartment. The third extensor compartment with EPL, this actually came up in my clinical short cases as a patient who had been treated for a distal radius fracture and then presented with a dropped thumb and an inability to extend the thumb, or extend at the IPJ specifically, isn't it? So this was a case of EPL rupture. And the treatment options available for this surgically move us into the fourth compartment, whereby a tendon transfer is possible if we use the ulnar slip from EIP to EPL. And that is one of the treatment options that we can discuss with patients with a suitable range of motion of the wrist and rehab potential, is a tendon transfer procedure. The fifth extensor compartment is important in the context of, for example, rheumatoid arthritis, whereby as part of the rheumatoid cascade, what happens is, the first thing in the rheumatoid cascade is supination of the carpus and distal ulnar prominence, something called that caput ulni, and you get subluxation of the ECU into the volar side of the wrist. But the whole point with rheumatoid arthritis is it's all inflammatory, and it's inflammation of tenosynovium, it's inflammation of synovium, and what happens is a combination of things. So the attrition from the prominent ulna, the caput ulni, the inflammatory response from the synovium of the Druge, and the synovitis from the tenosynovium can all cause rupture, first of EDM. And when you rupture your extensor digiti minimi tendon, you end up with a dropped little finger. What happens then actually is each of these EDC tendons make their way towards this site of sort of hot synovitis, and each of them then rupture in turn. So it starts with a dropped little finger, then a dropped ring finger, then a dropped middle finger, and a dropped index finger, and that is your pattern of tendon rupture in rheumatoid arthritis, and it's known as Vaughan-Jackson syndrome. Your differentials for a dropped finger, these could include, well, we've spoken about Vaughan-Jackson syndrome, but you can get sagittal band rupture around the tendon, again as a result of that synovitis. That could cause subluxation of the tendon, which mimics a dropped finger, easily correctable if you passively lift the finger and the patient can hold it themselves. It can also be due to MPJ dislocation, posterior interosseous nerve palsy, or a locked trigger finger is another differential for a dropped finger. Finally, the sixth extensor compartment is important because a patient may present to you with snapping ECU. This is a condition where a patient will present with ulnar-sided wrist pain. Again, it's an overuse pathology where you have a painful snap to pronation, going from pronation to supination. The treatment, again, rest, splinting, physiotherapy, or in a surgical option context, we could think about ECU subsheath reconstruction. But that is a very quick run through of your extensor compartments of the wrist and the relevant pathologies to revise as part of your revision for the FRCS.